Welcome, everybody. Welcome to this last open online briefing offered by Forest Foundation for 2023. That's not necessarily the last forever, but today David would like to reflect on the state of the world, just coming back from 2 weeks in Dubai at COP28. And David, I think you want to cover from health to food to your general reflections on international negotiations. So colleagues, as usual, we will first hear from David during about 20 minutes before opening the floor for your own reflections, reactions, questions, engagement, sharing your own views on the state of the world, the leadership that is required to keep moving on. Without long ado, I would like to invite David Nabarro for sharing his thoughts with us today. David?
Thank you very much indeed. I'd like to again greet everybody. Some people have appeared since I went round just now and said hello. So Claire Rayner, nice to see you there, smiling, excellent. And Zenda Offer, you made such an impact in our last briefing, Zenda, particularly with Michael Patton there. And it was really great to have had such a vibrant discussion on the way in which systems thinking and indeed systems working can give us a different insight on some of the issues that we're involved in. I want to start by focusing on COVID. And my reason for this is that, as many of you will have realized, actually from what you're hearing in your local communities, in the schools perhaps your children or grandchildren attend, and even in your places of work, there is a lot of respiratory disease around right now. I'm being cautious in my use of words always. The respiratory disease is associated with a number of different pathogens. Well, one is influenza. That, after all, is the commonest cause of a lot of unpleasant illness during winter months. It's very seasonal. And so there is indeed quite a surge of influenza-related illness in particularly the Northern Hemisphere. Secondly, particularly among children, there's a virus called respiratory syncytial virus, or RSV, that is causing quite a lot of sickness. And then there's COVID. And indeed, the juxtaposition of influenza, RSV, and COVID, plus a number of other pathogens that are also around, is leading to really remarkably high levels of respiratory illness. And in some cases, you've got a sort of half of classrooms with empty desks because children are staying at home because they're unwell. And it's not just in Western Europe and North America. There's a very high level of respiratory illness reported from India. There's a high level of respiratory illness reported from other countries in Asia, as well as from parts of Latin America. The COVID issue is vexing because, as many of you know, the capacity of this virus to mutate is well understood, and the mutants are indeed causing trouble. They are classified as variants of interest and variants of concern by the World Health Organization, and WHO is totally dependent on the capacity and will of authorities to not only test communities to see whether or not people have got coronavirus associated with infection, but also to sequence the viruses to see whether or not they represent a variant. Now, rather frustratingly, the variants have got all sorts of tricky names. There's one called BA2.86, which is a derivative of Omicron that was the last major cause that all of us were finding around the place. BA2.86 sounds like a kind of airplane airline reference number is in fact the code name for a virus that's been called Pirola, Pirola. It's the Pirola variant of COVID. There's another one, JN.1, that's been found in Kerala in India and has been associated with a big surge of coronavirus illness in that state. Does it matter? Well, we've said over these briefings that the natural progression of a pathogen like COVID is that over time, it will become more infectious and less lethal. That's, in fact, what we would expect from natural selection, that there is an advantage to the virus mutating in ways that make it more transmissible. And at the same time, it's very good for a virus if it doesn't kill the people it infects. And so the expectation as viruses settle down and become part of the biome ecosystem in which we all live, the expectation is that viruses just become less horrid. And so these variants that are emerging and that are becoming quickly quite prevalent are the variants that are highly transmissible and tend to be less lethal. Well, if only it was that simple. Of course, there are all sorts of factors that determine whether or not a person who gets COVID gets seriously ill and dies. One is the person's age. The second is whether or not they've got other diseases affecting them that put them at higher risk. And the third is the actual dose of infection that you get. If you get a lot of virus when somebody coughs over you or breathes over you, you're more likely to get sick. So what about these new variants? What do we know about them in terms of ages of people affected and the other diseases that make them particularly nasty? Well, I asked Maria van Kerkhove, who's somebody who we've had in these online briefings in the past, and she's helped us to understand what's going on. And she said to me that she does not believe that any of the new variants that are appearing are actually going to plunge us back into the extremely nasty period that we had in between 2020 and 2022. And that's because there's either an awful lot of people who've been vaccinated and an awful lot of people who've had previous COVID that leads to a fairly high level of immunity in society, which means that people are really not likely to get severe illness. The people who need to be on the lookout are people whose immune systems are not working well. And they are very most definitely older people, people who are on immunosuppressive medications, or people who've got illnesses that lead to their immune systems not working, like, for example, HIV/AIDS. And so we must not assume that everybody is somehow okay with this continuing movement of coronavirus in society. People who are immunosuppressed will be worried. And that's why I'm saying to everybody, please be really tolerant if somebody asks you to move away from them because they're nervous that if you're coughing, you might by perchance infect them. Please be very tolerant of people who are wearing masks in public places, like at meetings or in airports or on trains. They may be immune deficient and they may be worried that they're going to get COVID if you're coughing. And also, they may be people who've had COVID before and who've had it particularly badly. So they want to do everything possible to prevent themselves from being infected. I'm certainly encouraging people who feel they need to mask to have no hesitation about doing so. There should be absolutely no stigma attached to masking. And then I have to ask all of you to reflect on the reality that people still get really debilitating long COVID from these different variants, from Omicron and from its daughters and sons. And so there's a very, very good reason, especially if you had long COVID in the past, to be really careful about not exposing yourself. People say to me, well, if you're that worried, shouldn't there be mask instructions being given by governments right now, at least in health centres and other places where there's a lot of virus about? And I actually think that it's quite reasonable that hospital managers and senior clinicians should be putting round instructions about masking, especially if there's a concern that staff are being exposed, especially if there are peaks that are being picked up. The difficulty, and I have to stress this to you all, is that there's a real disinterest among governments everywhere in maintaining regular statistics on COVID diagnosis. It's almost as though people just don't want to remember that we've just come through a really horrible pandemic. And my colleague Maria was saying to me that she feels that there has not been a full grieving process in societies over COVID, and that this has led to a lot of people reacting to new information about COVID with frustration and with anger. Surely, they say, this has gone away. Surely we went through enough horrors in the period 2020 to 2022, and we don't need to have it visited on us again. And so it does lead to a degree of shutdown on concerns from biomedical and epidemiological experts, basically saying to them, stop it, we don't want to hear any more. We don't want to be worried about this. Could you please not talk about it? And that does create a difficult situation. We've seen it before in public health. Even after Spanish flu, there were communities that said, we don't want to hear from these medical types anymore. And it took a number of years before there could be open discussion about further risks associated with influenza. And the same applies, I believe, to coronavirus. There will be communities that just do not want to know about it. They are so traumatized by what they've been through. And then there are, of course, a number of people who are using social media to spread what I think most of us believe to be a quite unpleasant remarks about those who talk about coronavirus and COVID and seek to take action on it. And it's unfortunate that the misinformation, because it may well be dissuading some public health actors to take public positions, and it may be requiring that some people actually keep quiet about their anxieties because they're worried that this will disadvantage them. I look forward to hearing from those of you who are working with individuals who have COVID, or some of you may yourselves be affected by COVID at the present time, as to how you are handling this. I think it's an issue that we need to keep under review. And if anybody is finding that my relatively sanguine approach, which means that I'm not very worried about the immediate and long-term implications of the current spread of the virus, if anybody would like to question that, please do so. I'm conscious of it, I'm watching it, but I'm certainly not trying to talk to people in large numbers and say, you need to be taking action and precautions at the present time. I think that it's more important that we understand the kind of morbidity and illness that these new variants are causing before people like me start to raise the alarm. My second issue that I wanted to talk about just briefly is what's happened in Dubai in the last 14, 15 days. I was part of that community of nearly 100,000 people who traveled to Dubai to take part in Climate COP28. Florence and I were guests of the government of the UAE, And our role there was to work with the UAE as the host country on advancing a number of initiatives that the UAE wished to take place around the COP process. Their arguments were that the COP is a great place for negotiating what the world is going to do with the very limited carbon budget that is left. And that leads to a lot of negotiations. And there were negotiations around something called the global stocktake that concluded 2 days ago. But there was also intensive discussion in different forums about new ways of working in the health sector, particularly, and also in the agriculture and food sector as well. Let me describe the agriculture and food part. We did talk about it in the last OOB we had, so this is an update. The UAE government developed a declaration on sustainable agriculture, resilient food systems, and climate. That declaration was designed to be endorsed by heads of government. In that declaration, heads of government committed, if they signed it, to integrating work on climate and work on food systems in their national development strategies. Quite simply, the idea was that you don't think about food without thinking about what food is doing for climate and what climate is doing for food. And you don't think about climate, again, without thinking about its links to food, nutrition, water, and other related requirements. And that's because for the last 25 years, there has been relatively little connection between climate work and agriculture and food work. That's hugely important. Farmers are the first to feel the consequences of climate change in any society. Farmers tend to experience climate change much worse than anybody else. We've seen how throughout the world, climate change has accelerated in the last few years, leading to a big upsurge in levels of people's food and nutrition insecurity. Because water holes are drying up, there's often disputes over access to water. Climate change, particularly leading to droughts and dryness, is accentuating existing communal strife and leading to greater conflict. At the same time, very high levels of livestock rearing release large amounts of methane into the atmosphere. That methane goes right up into the higher levels of the atmosphere and contributes massively to global warming. Methane is much more potent as a contributor than carbon dioxide is. But not only do we get methane from livestock, also methane comes from paddy, from rice production. Methane comes from waste tips where old food is dumped. And so altogether, there are things inside food systems that contribute to methane. And if you add together the methane and carbon dioxide produced in food systems, it's about 1/3 of all greenhouse gas emissions. So it's kind of a really important thing to take into account, that if you want to do something about climate change, as well as dealing with fossil fuels, you also need to deal with food. Plus, at the same time, because climate change is affecting food systems everywhere, they need to be adapted so that they're not going to be damaged. Well, all this came to a fore. There was a declaration produced. 159 countries endorsed this declaration, an extraordinary number. And there was a huge upsurge of energy, focus on the links between food and climate in Dubai. And for some of us, this is a very exciting development. It builds on what we've been doing really quite intensively since 2008. And then it builds an awful lot on the Food System Summit of 2021 and on the stocktake that was done earlier this year. And yeah, our tails are up. This was an amazing achievement by the UAE government. Real courage, because they got such a lot of knocking in the run-up, and they're continuing to get knocked. Secondly, it was a real sign that you can use the COP not just for negotiating, but also for introducing new ways of working. And thirdly, what excited me the most was that it wasn't just the 159 governments that said, we're going to take this connection seriously. It was also businesses, farmer organizations, civil society everywhere, the research community, the philanthropic donors, and many, many others, cities, for example, as well, all saying we can do something about this. And the exciting part is that perhaps also those who are donors who provide concessional finance to transform food systems will actually increase their contributions, because right now we're in a food security crisis with very large numbers of people experiencing extreme food insecurity and real starvation potential, especially in Sudan and unfortunately also especially in Gaza. And this does call for really concerted action, but the money available to respond is very, very slim. So for many of us, getting food security right more central into the work in Dubai was really important, and we're all part of the follow-up. I'd be very interested in any observations on any aspects of COP28 if you wish to. So those are my opening remarks. Thank you very much indeed, everybody, for listening, and Flo, back to you. I know there are one or two folk who've got various comments they'd like to make.
I can imagine, indeed. I've seen body language while you were speaking, David. So that's the time when we open the floor to your own questions, reflections, comments on what David shared. And I will start with administrator. I think it's Ad Spikers. Ad, the floor is yours.
Good afternoon, colleagues, and David and Florence, congratulations. When I joined you a couple of years ago, David, it were the 3 C's: climate, COVID, and conflict. And you touched on 3 of them again in a very, very convincing way. I'm just from the plane, indeed, from Vietnam. And while you are speaking in Dubai, I was with a big group of people engaged in food security together in the Mekong Delta. And there the government launched last Tuesday the 1 million hectare high quality rice, with low carbon emissions. And I can tell you, David and Florence, what you just spoke and what you hear in Dubai, that was part of the reality there. And I'm very interested also to see that this example of Vietnam can have some spin-off. Coming back on the first issue of COVID, I was traveling a bit with my wife also in the public transport in Vietnam, but amazingly there in Asia, despite it is not obligatory, it is not forcefully, but people wear masks. About 70–80% of people in buses and public places wear masks. There is quite a bit of information also on the new developments of these diseases in China. And at least in that place, I see some positive signs. Coming back to food security, with David, he knows we worked on that in Bangladesh, in other places. You were yourself, both of you, in Vietnam in April when this was this UN food security, the stock taking exercise.
Yeah.
I believe that what I hear from David and what we can do together, David, let's take it on this 4 axes that we need to go to science. We have to go to innovation and data. That is, I think, all of us, we are aware. But it has to come to policies and strategies. And I was also happy to see in Vietnam, there were about 200 international guests. And happily enough, there were quite a bit of people from Africa. And some of them even came on their own finance. And it comes back to me then, South-South cooperation. I think that is really something we have to look in next year. But again, there a bit of finance is needed. David, you know, I was for 1 year based in Abu Dhabi, and I know the counterparts a bit. We should try in an intelligent way how we can profit the momentum which you saw in Dubai that the people like, for instance, in some Asian countries who have the technology, but not the financial means, that the Gulf states are willing to put something on the table and that we can tackle better the misery in Africa. David, today a new column is published here in Wageningen in Dutch. I will translate it in English, and I hope we can also use it in your website. But I'm very pleased with the outcome of Dubai, and I see the direct link. Last point, the foreign minister, Mr. Fat, is very much keen to walk further with you. That was not possible in April, but there are a number of interesting contacts. Thank you.
Beautiful to hear those words. And David, you are jumping to comment.
Well, it's just the joy when doing this kind of work is you find countries that take leadership roles on the interconnections between food, climate, biodiversity, water, and energy. And Vietnam has consistently been up there. The amazing ability of Vietnamese citizens, Vietnamese government people, Vietnamese business people, local authorities, and of course farmers to take this issue seriously. And climate change is affecting the salination of the Mekong Delta really quite badly. So in Vietnam, climate and food have been dealt with together, in fact, in the same ministry, as you're saying, for some years. And this amazing leader, Dr. Kap Do Phat, has been at the center of that in his combined roles of Minister of Disaster Prevention and Minister of Agriculture. So that's so cool, Ad, that you mentioned that. And for us, Vietnam and Cambodia in particular in the Mekong Delta, alongside a number of key African and Asian countries, have turned out to be real leaders at this time. Brilliant.
Your leadership of the platform in Geneva, I think we should give it a further push next year, David, and count on me, count a number of friends. They know about you, they know about your colleagues, and I really hope that we can make further steps towards Africa, because there more is needed.
Totally. Thank you very much indeed. Right, totally agreed. People here from Kenya will say that. Thank you. Sorry, Flo.
No, no worries. I was just thanking Ad for being a companion on this journey. Thank you very much. I would like now to invite Dr. Ray Duncan, who would like the floor. Dr. Ray, yes, you're here. The floor is yours.
Can you hear me?
Yes, very clear.
Can you see me?
Yes, and we can see your screen.
I have just a couple of slides. This is just very brief. I just wanted to, I've not been on here for a little while, and I just wanted to do a very brief update to talk about reinfection data. And obviously David has spoken at the beginning about SARS-CoV-2, the new variants, how they become more infectious. The acute index infection is generally becoming less severe, but people can get and are getting reinfected more often. This was one of the original papers from Zahid Al-Ali's group showing that the more times you get reinfected with SARS-CoV-2, the increased cumulative risk of not just long COVID, but cardiovascular disease, thrombotic disease, neurological disease, endocrine disease, and various other diseases. Back in April 2023, Dr. Tedros very clearly and publicly stated that an estimated 1 in 10 SARS-CoV-2 infections is resulting in the post-COVID condition. That's not 1 in 10 people, that's 1 in 10 infections, and did suggest that unless we get a handle on the high transmission rates, that hundreds of millions may end up requiring longer term care. So was that estimate right? Well, it looks like from recently published data from Canada that yes, it was. And this has just really recently been published from the Canadian team looking at a health survey of Canadians and showing that those who have had 3 or more SARS-CoV-2 infections have a 38% risk of having long COVID. So while I completely agree with David that the acute index infection appears to be getting less severe in individuals. I have to respectfully disagree that it is not still a concern because people are getting reinfected multiple times. I'm seeing this in my own patients in clinic, and the risks of long COVID are going up, along with the risks of quite a lot of other chronic diseases that COVID is involved in triggering, including cardiovascular disease, neurological disease, and diabetes, all of which are lifelong, life-altering chronic diseases. And we're already seeing quite a large impact only 4 years in on the economies of countries as a result of this increased burden of disease. And there has been a shift I've noticed kind of on the street, thinking that COVID is now akin to just being a cold or just being a flu. This was published yesterday by Zaid Al-Ali's group, and it's comparing COVID and flu directly. It is comparing it in hospitalized patients because epidemiologically that's much easier to do. It's much harder to do in the community because a lot of people aren't testing now, so the data is not as robust. But what it very clearly shows is that COVID isn't flu, and that COVID across 10 bodily systems has significantly worse health outcomes than flu, except for the pulmonary system, and it also confers a much higher increased risk of death compared to flu. Coming back onto the other things that COVID is still involved in, and obviously being a cardiovascular doctor, I'm interested in the cardiovascular side of things. We talked on here probably about a year and a half ago now about the damage that COVID can do to the inner lining of our blood vessels, called the endothelium. And we raised the concern at that point as to whether was this just happening in individuals with long COVID, or was long COVID potentially the canaries in the coal mine? Because we know that atherosclerosis, which is the disease process that causes cardiovascular disease for most people, is clinically silent and develops over many years, sometimes decades. Quietly, people don't know they've got it until they present with symptoms such as angina, heart attacks, etc. And what we didn't know at that stage was whether or not endothelial dysfunction, which is the precursor to the start of the development of atherosclerosis, was happening in everybody, whether they had symptoms or not after infection, was healing in those that were getting it. We didn't know what the impact of reinfection was on the blood vessels. And to a large extent, there's still a lot we don't know, but we're beginning to see some very small papers coming out now. And there's just two I wanted to mention very briefly, just for a minute before I hand over to Jeremy Nicholson, because I think what he needs to say is hugely important. This is a brief study looking at 142 plasma samples taken from patients who, some were hospitalized with COVID, so they were really quite sick. 19 of the patients weren't. They were either asymptomatic, with COVID picked up on routine testing in their acute illness, or very mildly symptomatic, so really mild index infection compared with non-infected controls. And this study looked at something called cell-free chromatin fragments, called cfDNA, that are released from dying and damaged endothelial cells. And what it found was that there was a significant, quite a huge increase in cfDNA from the hospitalized patients, which we would expect because we know SARS-CoV-2 has significant vascular effects on the cardiovascular system. But what we also found in the asymptomatic and mildly symptomatic individuals is that the cfDNA was also elevated in comparison to non-infected controls, suggesting that there is probable subclinical endothelial damage occurring, even in those with mild or possibly asymptomatic infection. Now, that's a very small sub-cohort of individuals. We don't know if that translates across the 700 million people that have been infected. We don't know what reinfection does. We don't know if it's healing by itself. But obviously, that's something that we've found that's a little concerning. This is another paper looking at cardiovascular effects, not looking at the endothelial damage. This is actually looking at arterial stiffness. So when atherosclerosis develops, it starts off with endothelial damage, and then you get foam cells, and then you get, it's layman's terms, it's cholesterol plaque disease and hardening of the arteries. So this study is looking at the hardening of the arteries side. And what they did is they actually had some data already looking at the hemodynamics and the arterial stiffness of a group of young adults pre-pandemic. So there was only 32 patients, but this group already had this data in 2019. And what they did is after these individuals got infected, they recontacted them and they repeated all of the same tests about 2 to 3 months out from their first index SARS-CoV-2 infection. The adult cohort, it was small. All of them had confirmed COVID on PCR testing. They were young. Mean age was 36.6 years old. They were generally healthy with lots of comorbidities excluded from those in follow-up. It was a real-world population of people, so there was a significant amount that were overweight, but you're still comparing them pre and then post, so that was kind of corrected for. And what they found is that from time out from index infection, it appeared that the arterial stiffness changes, the arterial augmented index, appeared to get worse rather than better. Now, again, it's a very small study. It's only showing 32 patients, and it's only followed up for about 3 months after SARS-CoV-2 infection, but they have concluded that certainly there appeared to be some widespread vascular changes that didn't appear to be getting better over the short time span that they were looking at it. So just coming on to where we are in the UK, again, this was just published a few days ago at the beginning of this month, looking at the excess mortality data since the start of the COVID pandemic. And what we've seen certainly from last year's data is that the excess death rates are still high. So we have about 1,000 excess deaths per week in the United Kingdom, about 500 excess cardiovascular deaths in England alone per week, over and above that we would expect for the levels of cardiovascular disease we have.
Right.
The increased excess death rate appears now to be in the highest in the younger to middle age groups. So that's 20 to 44s and 45 to 64. Now, not all of this is due to COVID. We know that. Some of this may be due to cardiovascular disease that we're seeing due to changes in NHS, backlogs, etc. But when we looked specifically at cardiovascular disease, ischemic heart disease was 44% higher, stroke was 40% higher, and heart failure was 39% higher. So I think that although the acute index infection from SARS-CoV-2 appears to be milder, there is a concern about cumulative reinfection and what that may be doing both to our vasculature and to our risk of chronic diseases. And with that, what I would really like to do, if it's okay with yourselves, is hand over to Jeremy Nicholson. Jeremy is a professor who...
Okay, the only thing, Ray, is that we've got a tiny bit of time left, and this is super important. I'm just going to ask Jeremy if just for this particular session, you could be super brief so that we can give time for others. Thank you very much indeed, Ray.
Thank you.
Thank you for this. And now I want to comment after Jeremy. Thank you.
So just to, can you hear me all right?
Yeah, very clear. Yeah.
Good.
Yeah.
So we are looking at this from a slightly different point of view. We're trying to look at all the metabolic effects of COVID and long COVID. And as you realize, this is a systemic disease, originally, of course, driven by the virus, but in long COVID, it's really immunologically driven. And that has a huge number of different organ-specific biochemical effects. And what we've been doing is using multiple cohorts from across the world. So we've looked at thousands and thousands of samples, assessing the biochemical effects of the acute disease and also long COVID. One of the things that I just wanted to say, to echo what Ray's just said, is that one of the things that we see very clearly is metabolic biomarkers that are consistent with changes in cardiovascular disease and also cardiovascular disease risk. And we see this in children as well. So there are certain lipoproteins that we can see in the body, like the apolipoprotein B100 and the A1. The ratio of those gives you a very clear index. It's been 30 years or more about cardiovascular disease risk. And we see that go up when you've got a COVID infection. And some people, it doesn't go back down even a year or so later, which means this is also asymptomatic. So one of the things that concerns me is that some of the biomarkers of biochemical change, the indicators that occur post-COVID, are things that are not associated with symptoms, but they are associated with changes in disease risk. And one of those things is cardiovascular. And we have a paper that's being considered by the Lancet at the moment, which is about these potential long-term cardiovascular risks in children. So I think that's probably, without showing you in slides.
Super important what Jeremy and Ray have just said. And it sort of coincides with an interesting piece in the Times of a couple of days ago, December 13th, which makes the point that there's been a surge in deaths in young to middle-aged adults in the UK since the end of the pandemic. And as Ray said, I hope you both don't mind me referring to you by your first names, but as Ray said, you know, yeah, it's COVID plus other things, but COVID seems to be a really important underlying risk factor. As Claire has written in the chat, this kind of increased risk would not have been considered acceptable during the pandemic. And Jeremy has pointed out that this is now changes in the structure of tiny blood vessels that's associated with changes in biomarkers for disease. It's all pointing to a real likelihood that in quite a lot of people, there are long-term changes in the way in which the body functions as a result of COVID infection. And the point that Ray has made, challenging me, and I was kind of, in a way, inviting you to challenge me by the way in which I framed the comments at the beginning. You said, come on, David, you might say that the current COVID infections are having less impact on people's health and life, but still they're at risk of long COVID. And long COVID, according to Ray and to Jeremy and to hundreds of other brilliant scientists who are studying it, is associated in some people with changes to how their whole cardiovascular system is working and the signs thereof. Have I got it right, Ray? I want to check that I've got it absolutely right, please.
I think from what we know so far, that's what the science is suggesting.
Yeah.
I think there's a lot of work that still needs done. There's a lot we still don't know.
Yeah.
And it would be wrong to say that all of these excess deaths are because of COVID. We know they're not all because of COVID. We do need to unpick that.
Yeah.
But certainly what the data is telling us epidemiologically and what the biomechanistic studies looking at what's happening in the body, one's telling us that it's definitely worse if you've had COVID, generally speaking. We're seeing these risks in young individuals that don't have traditional risk factors for cardiovascular disease, so shouldn't be captured in statistics for NHS delays because they shouldn't have the disease in the first place.
Yeah.
But also, there is, there is still a lot that we don't fully
I think
understand.
totally, and I'm so pleased that we are able to talk about things that are not yet cut and dried in these discussions. Jeremy, thank you for joining us and for sharing your take on the science. What we can offer to do, given who's here on this call, is to do a bit of short circuiting. We can share these concerns with our colleagues in the World Health Organization and elsewhere, and just ask them to keep an open mind. That's what we're really saying. Don't close it up, but keep an open mind. And in due course, the public will need to have information. We need to, as you say, got a bit of uncertainty to resolve. Thank you very much indeed, Ray. Thank you very much indeed, Jeremy. And also, I want to say thank you to Dr. Claire Taylor, who I can see on my screen. And Florence, if you don't mind, I'd like to invite Claire to come in now. Claire does occupational medicine and has really been quite badly hit by COVID herself. But Claire Rayner, I hope I may have got it super wrong. Claire Rayner does occupational medicine, been hit by COVID herself. And Claire Rayner may want to say something. Excuse me, Claire Taylor, for getting it wrong. Claire Rayner, please. You're muted.
Sorry, briefly in response, just to say that I am very concerned with the current situation, certainly in the UK. We have a lot of infection of all sorts running absolutely rife. People are being reinfected within 2 months, and they don't understand why, because they think they should be developing immunity, but I don't think people are developing immunity. So I think we're potentially in a very difficult situation. Yeah, I'd love to think people could still perhaps not go out and spread it around if they had a respiratory infection, whatever that is, and, you know, sort of take those sensible precautions. So yes, I guess I can only echo what the others have said already, and how important it is really to keep people well because of the effect on our workforces and so on. The things I'm hearing from the manufacturing sector are not good as regards the cognitive problems that seem to have resulted, and I think we should have some real concerns about what the effect of that in manufacturing of all sorts, and potential adverse outcomes. So I hope we can continue to have good public health practice, and I wish we had better public health messaging in the UK. I can't speak for other countries, but
could you just tell us a bit about what's happened in your life recently? It's rather special. If not, I'm going to say it, so I'm putting you on the spot a bit.
You say it. I'm not very good at bigging myself up.
Really? Well, most importantly, I have to say that you've had really an awful lot of COVID. It's been very hard for you, and very grateful to you for joining today. What's happened is that Claire has received an award from the Society of Occupational Medicine for outstanding contribution to the development of occupational health globally for her COVID-related work. Claire says that she's embarrassed to receive this award, especially as the people who nominated her have done at least as much as she did, but she really does feel that this is an award for the collective who've been working on this. She was too unwell to go and pick up the award from the Society of Occupational Medicine, and gave a rather lovely little statement to express gratitude. And I just want to say to all of you, the issues around long COVID, in my judgment, would not have got the attention that they deserved in 2021 and then in 2022 and onwards if it hadn't been for you collectively sticking together and saying we need to understand and then get greater attention to this issue, and continuing to do so. And I know that for each of you, whether it's Claire Rayner or Dr. Ray Duncan, or others working with you, you have had some real difficulties. We're going to hear from one more of the superstars in just a second.
Thank you.
Congratulations, Dr. Reiner. And
Thank
it's my
you.
pleasure to invite Dr. Taylor. We are really with stars here. Dr. Taylor, the floor is yours.
Thank you.
I just want to thank you, Claire T, as well as Claire R, for making this point so clearly. And we are in a situation now where the communication needs to be clear, strident, and at the same time done in a way that engages people and doesn't turn them off. It's really quite tricky. Count on us to do what we can. Thank you very much indeed for raising it. I saw Imam Ahmed put a really lovely light bulb up when she reacted just now, a sort of sign that this was something that was influencing her thinking, and that's great. And let's keep the word going round. Thank you for this segment. Thank you, Florence. Back to you.
Well, thank you to our doctors, really impressive. Congratulations to all of you and keep up the good work. But to other colleagues, even if you have not been awarded or on a great list to become awarded, you are most welcome to share your thoughts and comments here. So please do attract my attention so that I can give you the floor in the few minutes we have left together. Yes, it is time for a David summary.
Yeah, I want to go back to COVID. I want to pick up on something that's been said and that we have to just think about. There are people getting reinfected at a very high rate. And we heard that from Ray. She showed the graph. We heard it from both Claires, and it was Claire Taylor who was saying that she's really had it really a lot of times, as have others that she knows. It seems likely to me that the more times that people get infected, the more they are at risk of these cardiovascular challenges. It's a kind of cumulative build-up in risk as you get reinfected, so your risk rises. This is hugely important, and that's why this was identified. So just to say that point that's been made, I want us to hold on to it. Secondly, there are people who are concerned about the different variants that are appearing. Are these variants actually associated with differing levels of risk? And to what extent should we be worrying them? One person who is on this Zoom wrote to me quite recently asking about particularly the JN1 variant and said, is this something that should lead to a rethinking of risk? Well, personally, I'm not able to answer that question, but what I do believe I need to do following this discussion is to speak to my friends who work on the risks associated with these and other viruses and ask them if they can bring me up to date so I can update you next year on the relative risk associated with different variants. I'd like lastly to really acknowledge the work that we've all been doing in this year. We have been looking at COVID, we have been looking at the cost of living crisis, and we've been looking at the links between climate change and food systems. And we've been doing it with a very open series of minds. What we try to do in these meetings is to be open-minded and to accept that systems lead to interactions, interdependencies, and to quite a lot of direct associations that make it very hard to predict what is going to happen in life when new problems emerge. That's why we use systems thinking. That's why we try to teach people to be systems leaders. And what I believe we do in these meetings is to constantly remind ourselves that with systems approaches, it's vital to keep an open mind whilst at the same time accepting that science offers a really wonderful way in which to test hypotheses. And that's what each of us does. We test hypotheses as much as we can. Flo, there are other people writing in the chat, but I see that it's 1700 hours and here in Europe, and I want to go back to you. And if you want to pick up on anything else in the chat, please let us know. And I want to say to everybody who has written comments and everybody who participates, please stay with us because we're going to maintain this open-minded, wide-angle way of thinking, acting and leading as long as we can, because we think this is the key to working through some of the horrendous problems that our world and its different societies have to cope with, and the particular challenges that are increasingly being faced by people who've got very low incomes and very little agency. That's where we are, and that's where we will continue. Thanks again. Back to you, Flo.
Thank you, David. Beautiful summary. I will only add a point about the relationships that Karen Palmer was emphasizing in the chat. I think we do believe that relationships and connections is what can lead to changes. So that's also why we want to keep the group coming together. But it's our time to wish you a very healthy end of the year. Take care of yourself, take care of your families, your relatives, and we are looking forward to seeing you back in 2024.